first of all, a pleasure to have been your fellow, and now to work alongside you. It's quite a, in many ways, a dream come true, one that I probably couldn't have foreseen in residency, where I did almost no cosmetics. So after doing the fellowship, I feel much more confident using these lasers. And as well as, ASLMS, I had the chance to do a preceptorship with Dr. Goldman for a week, and I learned incredible amount of information there in just 1 week. So if there's any learners in this room here, if you can get a chance to do an ASLMS preceptorship with many of the people on this stage as well as an audience, that would be great. So I'm going to take off where Claire left off and talk about a few kind of scars and interesting patients I've seen over the last year and a half I've been in independent practice. I have no disclosures. So the first one was a person who, 32-year-old, 1-year history of a depressed scar on the right posterior shoulder. Scars in this area, when we do excision on them, they tend to spread a little bit. This one kind of caved in to a certain degree. When approaching surgical scars, this is an algorithm in DermSurge in 2016. They first assessed for issues with tension. Let's say if you have a tropion, you need to fix that first. With the potential Z-plasty, and then you assess for erythema, and then finally you assess for and treat scar texture and whether it's too depressed or too raised. Here we're focusing on the atrophic scar component. The major takeaway from this review that Dr. Ortiz has written is that combination treatment works best. Their options that they gave include fractional non-ablative lasers, such as the Erbium 1540, 1550, a fractional ablative laser, such as the CO2 or Erbium YAG, microneedling with or without radiofrequency, or occasionally injecting filler in the right area and in the right dilutions. So for this person, I started because there was this depression that I thought was a little bit deeper than usual. I started with the radiofrequency microneedling. I did 3 passes, and from 2 to 1 millimeter, and I saw that in a month it had actually improved quite a bit. But that when I tried to stretch the scar, there was this persistent kind of area that was still a little bound down. And I did subcision with the 18 gauge no-core needle, as well as some fractional non-ablative laser as well with the Icon XD 1540, just 3 pulses. And actually, after 2 treatments, the scar was completely flat. So I thought this is a case where, with just a few sessions, we actually made a huge difference. There was a little bit of persistent redness. I couldn't get a perfect picture because she moved out of town right after this 3rd treatment. So unfortunately, I've never seen her back after that. But it's just a case. And similar in this patient, 24-year-old engineer. This is a patient I've seen more recently. This is just from a bike accident, falling off the bike as a kid. 10 years ago, and has just a slight atrophic scar. I started with the 1540. I was actually fairly aggressive with this patient, but actually that made very little difference at a month. And he wanted me to be a little bit more aggressive, and I used the 1927. I switched devices from the Icon XD to the Fraxel, and where I was able to do 1550 plus 1927. And that actually provided a really nice result. And we were doing a few more sessions of 1927 from here on out because the scar the atrophy is completely resolved, and we're just dealing with a little bit of textural change on the surface now that the scar is flush with the skin. So my scar algorithm usually, especially for atrophic scars, is that there's easy things in dermatology like treating lentigines with a picosecond laser, and there's hard things in dermatology like treating surgical and acne scars. It depends on how old the patient is, what their nutritional level are, and everyone builds collagen a little bit differently. It also depends on the age of the scars. The older the scars, the harder it is to treat them. I usually assess for, I don't do Z-plasty, so if they need that, I would refer it out. But I assess for redness and pigmentation issues first, and then I deal with the atrophy. I usually start from deep to superficial, so if I need to do a radiofrequency with microneedling or subcision, I usually start with things like that first. And then I go to my 1540, 1550 fractional non-ablative lasers, and then I go to a superficial non-ablative laser, such as the thulium device. I usually can do multiple, maybe 2 of these modalities in the same setting, and then gradually shift down the line as they're getting better. Case number 3, this is a patient who had a very fun night, and in her driveway, as she was getting out of the car, she face planted onto her driveway, and caused this atrophic scar, and also she was not really concerned about the scar, funnily enough. She was really bothered by the slight bluish discoloration that was present at the deeper part of the scar. So that showed that it was probably some part of the asphalt or the driveway that was just microscopically in the dermis there. Just seeing what literature's out there for traumatic tattoos, actually, I was kind of surprised by how little there was. I found 2 cases in the Korean literature. They both used some kind of Q-switch or picosecond lasers. In this first case, they used a Q-switch 755 nanometer Alexandrite laser, and they followed that up with 3 sessions of Fraxel. And they got, after these 4 sessions, they had a pretty good result, as you can see here. The second patient, they combined the pulse dye laser because this patient had a little bit more erythema, as well as the picosecond ND-YAG 1064 laser, the PicoWay. And after 3 of these combination sessions, they were able to achieve a pretty good result. So at first, I was trying to tackle everything. I was treating both the atrophy as well as the traumatic tattoo. So I started with the picosecond 755, started in the dermis first, and I used both, PicoSure, picosecond laser. They have generally a full field setting as well as a fractional setting. So I used a little bit of both because the fractional setting sometimes helps with atrophy as well. And then I also subsized this because there was just this kind of clear cutoff, and so I did subcision the first time. I also did some fractional laser. I kind of threw the kitchen sink at her the first time. And after a month, actually there's some improvement, but at this point she thought the downtime was a little too much after the first treatment, and she didn't like the amount of bruising she had after the subcision. So we just went a little more gentle the second and third session with just the PicoSure, full field and fractional. And her final results were actually pretty good. Even though I didn't do any more subcision, I think the initial subcision over the first over a 3-month period has built up enough collagen where the scar was less deep, and the bluish discoloration was completely resolved. So the patient was really happy, didn't want any more treatments at that point. The last one I just want to talk about, we do a lot of sclerotherapy, Maryland laser skin and veins. We do a lot of vein work. And, sometimes the hallmark of a good doctor and good surgeon is to be able to fix the problems that you cause. So, this patient came in for sclerotherapy and had kind of a big cluster of larger telangiectasias on the shin. So we treated with a sclera polydocanol 0.25% foamed. For this patient. And the veins, after 1 session was completely gone, but she had this persistent hyperpigmentation. So when I treat people with sclerotherapy, I always warn them of 2 main side effects that are more commonly seen. So first, hyperpigmentation, especially on the shins, because there's just so little space between your skin and the bone. And second, I warn them about telangiectatic matting. Luckily, we have a lot of pigment lesion lasers in our clinic. So I just want to take a look at the literature. And actually, Dr. Goldman here was the first to report success with using the Q-switch Ruby. This was back in 2000. They had 8 patients who had persistent hyperpigmentation, because most hyperpigmentation after sclerotherapy is very transient and resolves after a few months. But in patients who had it for more than a year, he treated them with a Q-switch Ruby, and most of the lesions had 75% plus improvement, and he reported no complication. He even, in this difficult case in 2016, where the patient was taking minocycline and developed hyperpigmentation afterwards, the Q-switch lasers didn't work, the nanosecond range lasers didn't work, and he used the PicoSure 755 Alexandrite with just the focus, the fractional handpiece, was able to resolve this area of hyperpigmentation after 2 sessions. So in this case, I started with both full field and fractional laser. And then second session, there was some improvement, so I just did fractional after that, and we were able to completely clear the pigmentation. So, being able to fix your own mess is a big part of why I think patients, trust doctors. You have to, complications can happen to anyone, and to know what to do about them and to be educated about that is why, societies and training and societies like this, and why fellowship training is so important, and why I'm so lucky to have these guys every day. So, all right.
Thank you.